Let's go ahead and get started. So good evening, everyone. Welcome to ALC's Distinguished Lecture with Dr. Mazzone. My name is Elijah Davis, and I'll be assisting in moderating this event. So we're so pleased that all of you could join us this evening for what promises to be an insightful and enlightening event. So to go over the organization and structure of this, tonight's distinguished lecture will begin with an update from Executive Director Priyanka Senthil of the American Lung Cancer Screening Initiative. We will then have the privilege of hearing from our guest lecturer, Dr. Mazzone, and followed by Dr. Mazzone, we'll immediately jump into a Q&A session. So we'll go ahead and introduce Dr. Mazzone, but before we do that, we'll have Priyanka give some updates about the organization.
Wonderful. Thank you so much, Eli. It's so wonderful to see everyone, and we're really honored to have Dr. Mazzone here. And so, as Eli said, we'll start off with a brief introduction to the American Lung Cancer Screening Initiative. And since we do have a wide audience here today, we'll also be briefly introducing lung cancer screening. And so I'll go ahead with sharing my slides, and hopefully everyone is able to see this. So within ALCI, our organization is focused on two main goals: raising awareness of lung cancer and lung cancer screening in communities, primarily through grassroots outreach and advocacy, and two, increasing access to lung cancer screening among individuals who are at high risk for lung cancer. And the reason our organization is focused on these two goals is because lung cancer is the deadliest cancer in the world, causing more deaths than breast, prostate, and colon cancers combined. And lung cancer is very fatal because currently many patients are being diagnosed at a late stage when the cancer has grown and spread to other parts of the body. Lung cancer screening, however, is an effective imaging technique that can be used to screen for lung cancer and has been shown to catch lung cancers early. However, currently less than 6% of people at high risk for lung cancer are currently getting screened. And that's why we believe the education, advocacy, and legislative work that we're doing within ALCI is very much needed. So thus far, ALCI has hosted over 350 community events to teach people about lung cancer screening, and to help high-risk community members get screened. And the majority of these events have been formal presentations on lung cancer screening or tabling events where we have the opportunity to have one-on-one conversations with community members about screening. And going out into the community to increase awareness of lung cancer screening is something that we are really passionate about and excited to continue to expand upon. And we're currently working on an initiative to engage students across the country to increase awareness of lung cancer and screening. And so far, we've established over 30 ALCI college chapters across the US. And our goal with these chapters is to harness the excitement, energy, and time of college students to get feet on the ground, to go out into the communities, and to increase awareness of lung cancer screening. We recently launched chapters at Georgia Tech, Oakwood, University of Connecticut, Jackson State University, and we're currently working on establishing ALCI chapters at HBCUs, or historically Black colleges and universities, and key cities across the US where we have really strong community support. And we would love to share the work of our Boston, Chicago, and New York University ALCI chapters this past summer. These are a few photos from some of the events in Boston. We held lung cancer awareness events weekly in Roxbury, Dorchester, Mattapan, and Malden, which are predominantly Black neighborhoods. And at these events, we usually talk to 4 to 7 individuals who are eligible for lung cancer screening under the current guidelines. Our Boston team had over 30 events this summer in Massachusetts and directly talked to over 1,000 individuals. And during our events, we not only educate people about lung cancer screening, but also help them assess their eligibility for screening. We ask individuals for their demographic information and smoking history. And in particular, we collect their name, age, sex, race, and help them calculate their PAC year smoking history. And our team then follows up with these individuals, either through phone or email, to discuss next steps and options for getting screened. If they qualify for screening and are located in Massachusetts, then they will get a call from Mass General Hospital to schedule a lung cancer screening exam within 2 to 3 days. And from our efforts in Boston over the summer, we've actually been able to screen 20 individuals thus far. By establishing connections with lung cancer screening centers, we really are able to maximize the impact of our outreach by supporting community members through the process of getting screened. And we've also established a similar structure in Chicago and are collaborating with the UChicago Medicine Lung Cancer Screening Program, led by Dr. Jessica Donington. And we've had the opportunity to table at multiple health fairs, churches, as well as the Chicago Food Pantry. Recently, our Chicago team had a tabling event at the 62nd Annual Inglewood Parade and the 3rd Annual V-Day Parade. And at both events, the team had the chance to make a large announcement about lung cancer screening to the 1,000 plus attendees, and also set up a table at the parade to speak to interested individuals about screening. And at the Inglewood Parade, 200 lung cancer screening flyers were also added to informational bags that were handed out to the attendees. The UChicago team has also met with the Dean of Undergraduates, Lena Hill, and have planned to partner with facilities at UChicago to educate facility staff and faculty members about lung cancer screening. At UChicago, meals are catered by Chartwell's Dining, and Chartwell's Dining gave ALCI the opportunity to present about lung cancer screening to 40 of their employees earlier this month. And almost all of the 40 employees that we had a chance to talk to smoked, and several were eligible for lung cancer screening. And so next week, ALCI will be presenting about lung cancer screening to their entire crew of 500 plus employees. And all employees have Chartwell's insurance, which actually covers lung cancer screening. In New York, our ALCI team is collaborating with Mount Sinai, and we've been able to reach a wide variety of community members here as well through events with churches, health fairs, and Muslim centers. So the previous slides highlighted our work in raising awareness of lung cancer screening, but ALCI also does significant work at the local, national, and international levels in terms of advocacy. And so we've worked with over 365 governors and mayors from 50 US states and Canada to issue proclamations recognizing November as National Lung Cancer Awareness Month. And the proclamation on this slide is from Cleveland, Ohio, which is where Dr. Peter Mazzone is from. And the proclamations talk about not only the incidence and mortality of lung cancer in the specific state or city, but also discuss disparities in lung cancer among men and women, as well as racial groups. And here are a couple more proclamations that we've received from Ohio. And we've also had the opportunity to work with several leaders at the state level, including Arizona State Senator Leila Alston, who's a lung cancer survivor, former Pennsylvania Governor Tom Wolf, Lieutenant Governor of Colorado Diane Primavera, Congressmember Jake Auchincloss, Tampa Mayor Jane Castor, and 75 other leaders to film public service announcements recognizing and emphasizing the importance of lung cancer screening. On the leftmost side of the screen, you can see that we were on a Zoom call with the former governor of Pennsylvania. And at the beginning of the call, Governor Wolf had heard about lung cancer screening, but knew very little about it. And by the end of the call, he and his team were very well informed about lung cancer screening. We then worked with Governor Wolf to issue a governor's proclamation recognizing November as Lung Cancer Awareness Month in Pennsylvania, as well as a public service announcement about lung cancer screening. And we would love to take a couple of minutes to share this public service announcement from Governor Wolf.
Hi, I'm Governor Tom Wolf. November is Lung Cancer Awareness Month. Lung cancer is the deadliest cancer in the United States, but it doesn't have to be. Early detection can save your life, but only 8% of high-risk individuals are being screened for lung cancer. If you're between 50 and 80 years old, you've smoked for at least 20 pack years and currently smoke or have quit in the past 15 years, you are eligible for lung cancer screening. No one should have to suffer through lung cancer. It is important to raise awareness and get screened as early as you can. For more information, please visit the American Lung Cancer Screening Initiative's website, alcsi.org. Together, we can save lives. Thank you.
So this PSA was filmed back in November of 2022, and since then we've had the opportunity to work with over 80 other state leaders to issue more public service announcements. And one of the examples of another PSA that we received is from Tampa, Florida, Mayor Jane Castor. And in this PSA, Mayor Castor shares her personal connection with lung cancer. And our team further worked with her to publish an article on lung cancer screening in Tampa News. Furthermore, in 2020, we worked with the US Senate and House to introduce Senate and House resolutions recognizing November as National Lung Cancer Awareness Month and expressing support for the early detection of lung cancer. In 2020, the Senate resolution was passed, and here's a video showing that. So.
which was submitted earlier today.
The clerk will report.
Senate Resolution 780 designating November 2020 as National Lung Cancer Awareness Month and expressing support for the early detection of lung cancer.
Without objection, the Senate will proceed to the measure.
I further ask the resolution be agreed to, the preamble be agreed to, and the motions to reconsider made and laid upon the table with no intervening action or debate.
Without objection.
I ask the chair to lay before the Senate.
So when Mitch McConnell says with no intervening action or debate, this signifies that the Senate resolution was passed by unanimous consent, marking the first time the U.S. Senate has ever recognized the importance of lung cancer screening. This is a similar video for when the resolution was passed in November 2021, and we've also been able to do this in 2022 as well. And for this upcoming November, we're currently working with our Congress members on another lung cancer awareness resolution that will hopefully be passed by both the House and the Senate. And lastly, we want to share several new committees that we've recently launched within ALSI focused on different initiatives and efforts, from the ALSI Conference Committee, which is planning an ALSI conference in the summer of 2024, to the Primary Care Outreach Committee, which is spearheading efforts to engage primary care physicians in lung cancer screening efforts, to the Informatics Committee, which is leading the development and creation of a national lung cancer screening center database and interactive map. So at this time, I'd like to hand it over to Eli to introduce Dr. Mazzone in greater detail. Thank you.
Thank you so much, Priyanka, for that great information and those updates. So now it'll be my privilege to introduce our esteemed guest for this evening's lecture, Dr. Peter J. Mazzone. Dr. Mazzone is a world-renowned pulmonologist at the prestigious Cleveland Clinic, where he directs the lung cancer screening program. He's a pioneer in the field of lung cancer and lung cancer screening research, with a particular focus on developing and validating non-invasive molecular biomarkers. Through his groundbreaking research, Dr. Mazzone has made remarkable advancements in the early detection and treatment of lung cancer. He currently serves as the editor-in-chief of Chest Journal, the leading publication in pulmonary, critical care, and sleep medicine. Dr. Mazzone also served as chair of the Thoracic Oncology Network for the American College of Chest Physicians. We are honored to have him here today to share his invaluable insight and expertise. During his presentation, we'd like to invite you, members of the audience, to be thinking of questions to ask Dr. Mazzone about his research and about lung cancer and screening for the Q&A session that will immediately follow. And with that, I'm pleased to welcome and hand the mic over to Dr. Mazzone.
Thanks very much for the very kind introduction and the kind invitation. It's really amazing how much energy this group has brought to this this important cause, and I hope you're very, very proud of yourselves. It's extremely impressive and will be appreciated by many. I'm honored to be giving the talk today, and what I'm going to do during the talk is kind of introduce the topic to you, and then I'll provide you with a little bit of an outline, and we'll get through the presentation. I'm happy to answer any questions that come up. These are just funding to my institution or my disclosures for various research projects. So the basic fundamentals of the talk, before I give my outline, I just wanted to go over a few definitions and basic principles to help frame the rest of the presentation. So we're talking about screening today. So screening means we test somebody who's at risk for developing a disease before they have any symptoms or signs of the disease, in hopes that we catch that disease earlier than we would have if we waited for those symptoms or signs to develop. The reason to do so would be if the disease itself is better managed when found early in its course. So a screening test has to be able to detect preclinical disease at a point before it's become untreatable. And ideally, it detects little else and doesn't cause much harm itself. At the end of the day, if you're judging is a screening program successful, the measure we use, the outcome you're looking for, is do fewer people die of the disease that you're screening for. We can look at this in a different way, and this will come up throughout the talk is really a balance between the benefit and the potential harms of screening. The benefit is fewer people die of the disease you're screening for. The potential harms are from the performance of the test or findings of the test. Do you find things you don't need to, and the evaluation of those findings can lead to harm to those patients? I also include cost on that harm side. Now, you'll notice here a few very unique things. One, you're screening. So you're testing somebody who's otherwise healthy. And so had they not come to you, none of the potential harms would have fallen on them. So it's very important to make sure we're not hurting this group of healthy individuals. The other is that very few people, just a small percentage, ever find the benefit from screening, ever find that disease, in this case, lung cancer, and then have their lives saved. And everybody's exposed to the potential harms. So you have to be able to justify to the group as a whole the benefit to a few. Why might that be something that you'd be able to prove? You know, the value of the benefit, someone doesn't lose their life from lung cancer, is much, much greater than any one individual harm, finding a small lung nodule, for example. And so the value has to come into play when you're deciding which way this balance is tipping. Once you start talking about values, the individual's own value set becomes very important. And that's where the fulcrum really comes into play here. If somebody's very afraid of any of the potential harms, that fulcrum might shift. If someone's, willing to go through testing just to be absolutely sure they get the benefit, then that fulcrum may shift also. Other influences can shift that fulcrum. The quality of screening will shift the fulcrum. Are you able to get someone to stop smoking? Do you manage how sick is that individual with other comorbid conditions? All of those things can shift this balance a bit and need to be considered as we talk about the current state of lung cancer screening. So with that as background, I'm going to touch briefly on the evidence base for benefit and harm side of the balance. And then I'll talk to you quickly about 10 different components of high quality screening that can influence that balance. If time permits, and I've asked the moderators to tell me if I'm going too long here, I'll talk a little bit about molecular biomarker development and how it might shape lung cancer screening in years to come. Well, the first is the benefit. The earliest studies of lung cancer screening used chest radiography as the screening test. And interestingly, they were able to find higher survival, longer survival of screen-detected lung cancers than of traditional symptom-detected lung cancers. However, when controlled studies of lung cancer screening were done, they found a few extra early stage cancers, but there was no difference in how many advanced stage cancers, so no stage shift was noted. This was very important information for shaping how low-dose CT imaging was viewed as a screening test. Ultimately, when you look at controlled studies of lung cancer screening with chest radiography, no benefit. There weren't fewer deaths noted. The end of that debate or discussion came from the publication of the PLCO study, over 130,000 individuals randomized to chest radiography for screening or no screening at all. You'll see here that this group had a moderately increased risk of developing lung cancer. So almost half of the individuals had never smoked, about 3 times the lung cancer incidence of the general population. Chest radiograph arm found slightly more lung cancers, but not a lot of them were screen detected. Many were detected in the interval between the annual chest radiograph. And then during the lengthy observation period, most of the cancers were found. End of the day, they found more early stage cancers, but there was no difference in lung cancer deaths, no stage shift, no mortality reduction. And so chest radiography is not a screening tool to use. Imaging was improving while those studies were going on, and CT imaging became much more commonly used and clearly could show smaller nodules, smaller cancers than you could detect with chest radiography. And so a series of first cohort studies where everybody gets the low-dose CT scan were done, showed promising survival benefit. Now, the lessons learned from chest radiography suggested that's not enough. We need to prove mortality reduction despite that survival benefit. And so controlled trials of lung cancer screening with low-dose CT were initiated. And the first to show a mortality benefit was the National Lung Screening Trial, published in 2011. And then the second confirming those findings was the Nelson study, published in 2020. You will see some differences between these studies that helps to inform the current state of lung cancer screening, differences in enrollment or eligibility criteria, differences in how frequently and for how long patients were screened and followed, differences in the control arm between those studies, differences in the size of a lung nodule that was considered a positive finding. At the end of the day, they both showed mortality reduction, approximately 20% in the NLST and 27% in the Nelson study. When you look at the same types of table that I showed for the chest radiography PLCO study, you'll see some significant differences. Here, everyone was high risk. There were no individuals enrolled who did not smoke cigarettes. The incidence of lung cancer was now about 10 times that of the general population. The more sensitive test, the low-dose CT scan, most of the cancers were screen detected, with far fewer in the interval between annual screens. And Nelson had not just annual, but it spread out over time screens, and fewer in the observation period. End of the day, more stage 1 lung cancers in the screening arms, fewer lung cancer deaths. There were other studies, controlled trials. They weren't powered. They weren't large enough to find a mortality difference. But when you add them all together in a meta-analysis, comes out in favor of low-dose CT scanning. So a benefit has been proven for low-dose CT scanning. The other side of that balance are harms, and we have to be aware of them to maximize the net benefit for our patients. The most commonly discussed, most serious, is that we find a lot of lung nodules in patients who get scanned, and most of those nodules are not malignant. The frequency of lung nodules depends a little bit on what you call a positive result on the scan. So the National Lung Screening Trial said 4 millimeters or bigger, and that was about 39% of everybody who was screened. If they had said any nodule, it would have been 80% of everybody screened. How often do those lung nodules end up getting biopsied or having procedures where the real harm can be found? It depends a little bit on the study length and the study design, with some variability. The best data comes from the National Lung Screening Trial, where a little over 4% of individuals underwent an invasive procedure. This was a baseline and 2 annual screens. Just under 1% had a procedure-related complication, and 0.3% a serious complication. 22% of all surgeries were performed for benign disease. So you took a healthy person, scanned them, ended up having part of their lung removed, and there was no cancer there. 37% of all non-surgical procedures were performed for benign disease. So that means bronchoscopy with biopsy or a needle biopsy. The other two harms commonly discussed but harder to quantify are overdiagnosis and treatment. This means you find a lung cancer that never would have hurt that person. Maybe it was very slow growing, or maybe you were screening somebody who was quite sick with heart or lung disease and they would have died of something else earlier. There's estimates that at least one lung cancer was overdiagnosed in the National Lung Screening Trial for every lung cancer death that was avoided. Radiation exposure from repeated imaging, again, a lot of debate, felt to be quite safe, but at least one estimate of one radiation-induced cancer for 108 lung cancers detected if you screen people for 10 years. When we put that data on that same balance, most stakeholder societies favor the benefit over the harms. So if you use the National Lung Screening Study criteria, 55 to 74, 30 plus pack years, smoked in the last 15 years, it would have taken 320 individuals to be screened to avoid one lung cancer death. Those 320 individuals, 125 would have been told they had a lung nodule, 8 would have had a biopsy, nobody a serious complication, 1 cancer would have been overdiagnosed, nobody would have had died from the radiation risk, and you had reasonable cost effectiveness. That balance is felt to favor benefit, but you can see that by some shifts in this fulcrum, the balance could tip one direction or the other. And that's where implementation becomes extremely important. So this is the same way of looking at that data. Now, 1,000 individuals, 3 fewer deaths, 18 people still die of lung cancer, 365 lung nodules, 25 of those end up being biopsied, 3 have serious complications, and 4 people are overdiagnosed with a lung cancer. That's the favorable balance. But if you roll this out into practice and you have a higher nodule detection rate, or you do more surgeries for benign disease, or you're not capable of managing patients' anxiety about being told they have a lung nodule, or you start to screen a lot sicker people, you can understand that that balance may shift. Now, that's framed in a negative tone. I could have said the opposite. If you find fewer nodules, you're more skilled at talking to people. You are more skilled at assessing nodules, and you don't biopsy as many. You could tip the scale more in favor of benefit. And it is real world here, real world implementation. This was 8 VA sites in an implementation study. And overall, between those who were eligible and agreed to be screened and end up being screened, only about half of all individuals actually wanted to be screened and got screened. But 1 in 8 had a worrisome looking nodule. About 2% of everybody had a nodule that wasn't just worrisome, but suspicious enough to consider biopsying. That's a greater percentage than the percentage of cancers. When you did find a cancer, most of them were early stage. There were a lot of other findings on the scans to deal with, and a lot of variability in how the sites performed in those metrics. So with that in mind, how might we consider high quality implementation? And I have 10 points, 10 components of a high quality program to go over. The first related to the program structure. You can structure a screening program in a centralized way, in a decentralized way, or in a hybrid. Decentralized means a primary care provider is going to identify a screen-eligible individual. They talk to them about screening. They get the report from the low-dose CT scan and manage all of the findings on those scans. And then they ensure that the patient comes back the next year. In a centralized program, the program is responsible for those things. A provider may identify an eligible person, they refer them into the program. Program's designed to provide shared decision-making. They have radiology colleagues read the scans and report them in a structured way. The program manages all the findings, ensures adherence, and directs quality improvement initiatives. In between those extremes, you can see how a program may help primary care providers do some of these activities. There is no one right or wrong. In the literature, the centralized approach tends to have a little bit better follow-up of patients and adherence to annual screening. And that's how my program functions, because I feel that the quality difference is real. Number 2 is, who do you screen? Now, this is easy enough. You screen eligible folks based on the United States Preventive Services Task Force, Medicare, and insurance coverage. But it is a very interesting academic discussion. And so I'll just share a couple of the points that are top of people's mind. What about at-risk individuals who aren't eligible? And this study looked at individuals who had smoked at least 20 pack years, and had quit more than 15 years out. And you could see 25 years or more out, there was still about 4 times the risk of developing lung cancer as somebody who had never smoked. Right now, we're selecting individuals to be screened preferentially in individuals who may not have the greatest net benefit from screening. So the greater number of comorbidities or functional impairments actually has a higher rate of screening than those who are healthier and might benefit even more from being screened. Eligibility criteria led to inequity in access to screening early on. That's been largely modified, though there are still some disparities in terms of access to care. Another way to deal with the other high-risk individuals and to ensure more equity in eligibility is to use a risk calculator. Risk calculators have been shown to be more efficient. You can find more lung cancers than guidelines while screening fewer individuals, and to be more equitable in who they identify as being screen eligible. However, some of the factors that are included in these risk calculators may not lead to higher net benefit from the program as a whole. So the risk calculators include variables like age, COPD, other comorbidities, prior cancers, and those individuals identified through the risk calculators may have higher competing risks of death. Overall, if you think of both sides of that balance, and you say, how might a person identified by a risk calculator fare on either side? Poorer survival after treatment of early stage cancers. They may have different lung cancer phenotypes and higher competing mortality. They're more likely, because of sicker lungs, to be found to have a lung nodule, more risk from an invasive procedure, and more complications from surgery. That same fact comes out in a few studies that look to see what is the optimal eligibility group. And this here is using various risk calculators and comparing it to the older USPSTF criteria. And this line of efficiency is the best benefit, here labeled as lung cancer deaths prevented, to harm here labeled as how many CT scans are done. And you can see that you get more bang for the buck with the risk calculators than with the common criteria. However, if you change the benefit from lung cancer deaths averted to life years gained, you'll see now that USPSTF criteria is right in line with this line of efficiency. And the only way to get that separation again would be to add a variable of life expectancy. USPSTF, when they changed their recommendations, when they broadened their eligibility criteria, they did that same exercise. This is current eligibility criteria. When the benefit is deaths averted, it doesn't quite meet the line of efficiency here. But when they change that benefit to life years gained, then the current eligibility criteria is right along that line of efficiency, and that's what they used. Now, if a risk-based calculator includes increased portions of elderly people, the older you are, the more likely you are to be eligible. What if instead we looked at a life gained or a benefits calculator? Here you can see age kind of truncates that. Risk-based individuals down here, life gain-based individuals here tend to be younger, have fewer comorbidities, and ultimately may have a greater net benefit from screening. The challenge here is that it's very difficult to calculate these life gain-based strategies, multiple variables, hard to implement into a primary care practice, so nothing quite ideal. End of the day, with all of that background, these are some guidelines produced by the organization I'm part of, suggesting who should be screened, those who are eligible for the NLST for sure, broader criteria as per the USPSTF update after the Nelson trial was published. Yes, we think they should be screened as well. And then for those that are high risk, but aren't included in those recommendations, and you think that they still have a high net benefit from lung cancer screening based on the results of risk prediction and life expectancy estimates, or on life year gain calculations, we also suggest annual screening. Some of the caveats are those the individuals who meet eligibility by this set of criteria, may not be covered by insurers. So the third component of high quality screening is, how do you actually find these folks and get them in? We're all here because uptake of lung cancer screening has been relatively slow compared to what we'd hope it would be. We have some studies in the literature that suggest characteristics of individuals who are less likely to come to be screened. In this study of our own group, not being aware of an appointment, being worried about insurance coverage, being far from the screening site, were all variables that might have led someone not to come in for their screening visit. In our own screening program, there are a couple of tools that we use to help identify and schedule patients. We centralized our program after Medicare approval. On main campus of our health system only, we plateaued at about 40 to 60 individuals a month. We added a few sites to make them closer to patients. The following year, we got up to 100, 120 individuals a month. We put a best practice advisory live in our electronic health record, and referrals went up fourfold overnight. We had to shut it off because we couldn't handle that volume. We recruited up more individuals, more sites, turned it back on about 6 to 9 months later, and again, had that fourfold increase. We climbed to nearly 500 a month. When COVID hit, we had to shut down in-person visits for a couple of months, reopened quickly with virtual shared decision-making visits, plateaued again around 500 a month. The USPSTF criteria were expanded, and then we did direct outreach through our electronic health record to individuals with smoking histories and age that suggested they were eligible. And we've peaked at around 1,000 a month in our health system at this time. Number 4 is shared decision-making. Shared decision-making means you're talking to patients, you're collaborating with them, sharing the best available evidence, and trying to incorporate their values and preferences into this decision about whether or not they should be screened. The goal here is that you elicit their values and you support them. And you might do so by using tools such as decision aids to help educate patients and bring out their values. Ideally, their decision ends up being in line with their values and their own goals of care. There are some studies suggesting that shared decision-making, decision aid tools help to improve patients' knowledge. They lead to low conflict with their own decisions after those decisions are made, and those tools can be quite acceptable. The challenge is it's not really a one-size-fits-all. You'll have some individuals, high risk of lung cancer, very healthy, so high net benefit. And you really want that message to say, please be screened. You have others that are either low risk for having lung cancer, or they're quite sick with other things that are more critical to their long-term health. In that shared decision-making, you'd really like not to expose them to potential harm of screening. And then in between there, you have a lot of preference-sensitive people. And so it's quite a skill to be able to have these conversations across this spectrum. Guidelines suggest components of shared decision-making and how you might conduct shared decision-making in centralized versus decentralized programs. Smoking cessation is number 5. It's a nice time to talk to somebody about quitting smoking, as important as the screen. There's some suggestion from screening studies that individuals, particularly if they're told they have a lung nodule, might be more likely to quit smoking. Despite that, there aren't any studies really showing an intervention attached to screening leads to improved abstinence from cigarettes over time. Guidelines currently simply suggest that smoking cessation guidance should be part of all of lung cancer screening program visits. In our own program, when we put together those shared decision-making and smoking cessation, we review patient eligibility. We have about a 6-minute video explaining risks and benefits of screening. We use a decision aid at shouldiScreen.com. We discuss the likely findings, stress annual screening, and talk about how we'll share the results of the scan we incorporate smoking cessation, and we document in a way that can be extracted into a database to help us follow patients. Number 6 and 7 are about the lung nodules themselves and the scans. We have great partnership with radiology. It's important that we're tracking the radiation dose to make sure we're minimizing harm. Our radiologists provide a structured report to provide us with guidance about the findings and how we might manage those findings. Lung nodule management is the biggest component of those findings. There are guidelines available for how often you follow low-risk lung nodules. Those guidelines are pretty consistent for small solid nodules, a little more variable for subsolid nodules. The bottom one here is lung RADS, designed specifically for the screening population. This is the latest lung RADS iteration. There were some changes published late last year with the manuscript set to be published in another month or so that I think make for clearer guidance for how you manage small lung nodules. It's important to notice that the positive criteria in lung RADS is a 6 millimeter nodule, whereas in the National Lung Screening Trial, it was a 4 millimeter nodule. And you can see the trade-off there. You may delay a few cancer diagnoses, but you minimize how many scans are done. And so it becomes extremely important that these very small nodules, those ones that could be cancer, are followed closely. Larger nodules are managed based on their risk of malignancy. It's important that this skill set is part of any lung cancer screening program. Out in community settings, there tends to be higher incidence of biopsying benign lung nodules and more complications, both by age and by the type of procedure. And so it's critical that this is managed well. Guidelines suggest that any screening program have a comprehensive approach to lung nodule management that has access to multidisciplinary expertise, and that we particularly are careful to avoid overdiagnosis and overtreatment of potentially indolent cancers. Number 8 is how will your program manage the other findings on the scan? You don't just see the lungs and the lung nodules. You might find other pulmonary diseases, coronary artery calcification, nodules or masses in other locations. In our own program, about 1 in 7 scans find something else, and about 1 in 8 leads to additional testing. There are guidelines available for how you manage most of those other findings, including some white papers from the American College of Radiology that are really quite helpful to include as part of your comprehensive program. Guidelines suggest that this strategy for managing these non-lung nodule findings be built into every screening program. Number 9 is compliance with testing and annual screening. The benefit in NLST came with a compliance of 95% over 3 years. And we know that we're not coming close to achieving that. The NLST population was slightly different in makeup than those who are screen eligible. And some of the differences are features that in the past have been shown to predict non-adherence with follow-up of screening tests. In the first 1 million people reported to the ACR's registry, annual adherence was about 23%. In this study, it was about 40% higher in a centralized program arm than a decentralized program arm. When you pay attention to those patients here, a navigator, program coordinator was able to increase this program's annual adherence from about 25% up to 70%. Guidelines suggest a strategy be developed to maximize compliance with annual screening and evaluation of screen-detected findings. And finally, every program should have some way to judge how well you're doing and improve your quality. There are 6 validated quality metrics for lung cancer screening those who are screen eligible, smoking cessation interventions, compliance with annual screening, compliance with follow-up for category 3 and 4 findings, and the time it takes you to diagnose a lung cancer in somebody with a 4B or 4X finding. So that's a definition, a little bit of the evidence base to support net benefit from lung cancer screening, and then a top 10 of implementation and how you implement high quality screening to maximize that net benefit. I'll just ask whether or not you want me to speak for another 5 minutes or so about molecular biomarkers, or if you'd like me to break here for questions and answers.
Yeah, thank you so much, Dr. Mazzone. I think with that, we'll go ahead and jump into the Q&A section with the time we have remaining. If that's all right with you.
Perfectly fine. Yep, absolutely.
Okay, so just some instructions for this. We're going to transition into the Q&A portion of this event. So I'd like to open up the floor to all of you for any questions you have for Dr. Mazzone regarding his presentation or expertise in lung cancer screening and detection. So when you're asking your question, if you could please just wait for the mic and state your name before speaking. We'd prefer that you do ask questions via video on Zoom, but if you're not comfortable with that, please just send them in the chat and we'll read them off to Dr. Mazzone. And then if you could just go ahead and queue yourself in line by using the raise hand feature. And then, yeah, if you're ready to take questions, Dr. Mazzone will go ahead and start.
Of course.
Awesome. I'll jump right in, I guess, first, and then I see Dr. Gieske has a question, so would love to hear from him as well. But Dr. Mazzone, I was just curious, something we come across a lot in our community outreach is difficulty assessing eligibility for screening, and in particular, difficulty in the pack year calculation. And so, like, oftentimes we will meet someone and we'll ask them how many cigarettes per day on average do they smoke, and they'll say 5, and they'll give you a very straightforward answer, and they've smoked 40 years, 5 cigarettes, have a 10-pack year smoking history, they're ineligible. But then you might say, well, when you were 30 years old, how many cigarettes per day were you smoking? And they're like, oh, back then it was, a pack or even 2 per day. And so it always gives us a very uneasy feeling in that it's like, obviously this representation of your tobacco exposure is inaccurate. But unfortunately, given the current guideline, you're not eligible for screening. And so I would love to get your insights on what you think about pack years. And yeah.
Yeah, I think that it's a very good question and very insightful. And taking that smoking history is critical because you don't want to miss the opportunity to screen someone who's otherwise eligible. And people smoke more, they smoke less, they quit for a few years, they smoke again. And so being as detailed as you're able to with that smoking history becomes very, very important. What age did you start? And, what's the most you smoked? How long did you smoke it that much? Those sorts of details become critical. When we're trying to do outreach through the electronic health record, it's also an issue because many times the smoking histories either aren't documented or they aren't documented well. We've tried to overcome that in a few ways. We have, through our electronic health tool, sent messages to individuals who don't have smoking histories documented, but are in the age range where they'd be eligible for screening. No tool is perfect. We found about 40% of those individuals we invite to give us their smoking history end up filling it out on their phone or online. And then maybe 20% of those individuals are screen eligible, and we're able to reach out to them and try to get them in. So multi-pronged approach, but your point is exactly right. It's very difficult sometimes to know exactly what someone's smoking history is unless you ask with a lot of detail and care.
Great, thank you. And then Dr. Gieske has a question. Sorry.
Okay.
There you go.
There you go.
Gotcha. Yeah, I was unable to unmute myself. It says the host wouldn't allow. Yeah, my question is regarding the BPA, Peter, and great presentation, by the way. I'm with St. Elizabeth Healthcare, and we instituted our BPA in about the same time, about 4 to 5 years ago. And we noticed a similar uptick in the uptake following that. unfortunately, and this, I did not initiate this, but we are reevaluating our BPA in our healthcare system now. Providers as a rule hate BPAs. They're an annoyance. It was put in place for good reason, I think 4 to 5 years ago, and I still feel like it has a place. There is some discussion around making it a softer BPA and putting on the left hand of what we refer to as a storyboard. We're an Epic shop, and Epic has a mechanism where they can somehow make a little bit of a yellow highlight if somebody is due for a health maintenance screening. I'm just kind of curious if you're experiencing similar pushback or if you've had to deal with that in your healthcare system.
Yeah, definitely.
Cleveland Clinic.
Definitely. That getting the BPA in was an issue. There's committees on committees to do all these sorts of things. And then the transition away from BPAs happened here as well. There was a lot of fatigue with BPAs. And so that's how it was then. Right now, we have lung cancer screening included in our health maintenance tabs, as opposed to as part of a BPA. In the primary care providers, when an MA rooms their patient, they'll look at that health maintenance tab and attempt to pre-populate orders for the referral. In our outreach efforts, it's clear we're still, despite being very busy, impressive sort of numbers, we're still missing all kinds of people who could be screened. And so gives us, more challenges to think of and overcome. But yeah, we transitioned to a health maintenance tab.
So, and then Lucia Sequist, if you'd like to unmute yourself.
Great. Hey, Peter, great talk. So I have a question from an oncologist point of view, which is about overdiagnosis. And how do you think, what do you think are the metrics that we should be using as we're examining different populations that have been screened to try and determine if some of the cancers diagnosed were potentially designated as an overdiagnosis?
Yeah, I think it's a really interesting question. And it comes up a lot because, we see individuals, right? We see a person and you say, hey, I can still find a cancer nowadays. We can treat this small cancer without a whole lot of morbidity. And that's a face-to-face, one-on-one individual level. And you may never know, would that cancer have killed that person with severe emphysema or bad heart failure, or would the other disease have? Where it becomes a more challenging principle or something to put into policy is, on the whole, when you're setting up that policy, it's a screening population level that you're looking at. And on the whole, those sicker individuals have less overall benefit from finding the early cancer and more harm. Our sick lungs always have lung nodules, and lots of them look worrisome for cancer, and they don't do well with biopsies and so on. So on the whole, on a population level, it's very important to try and define who's too sick to benefit, who are we potentially overdiagnosing and overtreating. And those are challenging. It's hard to calculate a life expectancy and tell someone you're not going to live long enough to benefit here. But I think it is on us to kind of have those sorts of thoughtful discussions so that we have a greater chance of an overall net benefit of the program. The other type of overdiagnosis, overtreatment, has been even more challenging to talk about, and it's the obvious ground glass nodule that's an indolent cancer, but when will it turn aggressive? That's very hard, right? You're okay. Don't ever take those out. That's overtreatment, but you need to find them, follow them, and if someone's well enough, long enough, you're going to treat it. It's really, I think, the harder is the overdiagnosis type 2, where somebody may just be too sick to benefit.
Thanks.
Awesome. Thank you, Dr. Sequist and Dr. Mazzone, for your response. Dr. Gandhari, if you'd like to go ahead with your question.
Okay, can you hear me? Okay, it wasn't allowing me to unmute. Dr. Mazzone, thank you so much for a very wonderful, comprehensive talk. I'm a pulmonologist in Los Angeles at Cedars-Sinai, and about a year ago, we launched a hybrid lung cancer screening program. And the question I have for you is, one of the challenges I've had as the person directing the centralized portion is the issue related to a program sort of taking over the care of the patients. And a lot of times there's a lot of hesitancy allowing the program to sort of use models like a BPA or reaching out to patients with the fear that we're going to impact the community providers and seem as though the big Cedars-Sinai is trying to take over the community. I was wondering if you had any advice in terms of those of us who are really trying to improve the care within the community and actually have resources to do so, to, in a sense, create a language or a system that actually would be more welcoming and accepted, so that there's that hesitancy doesn't exist within the leadership, or whether it's in radiology or in other areas.
Yeah, that's another real world issue, and we've certainly experienced it ourselves and continue to as our health system kind of expands out. So we have Cleveland Clinic employed primary care physicians across Northeast Ohio. That group, it took some education and convincing, but for the most part, they were comfortable and favored the centralized approach. They recognized in our health system, it's 90% of everybody has a lung nodule. There's lots of non-lung nodule findings. And so 10, 15 minutes they get with the patient, it's tough to handle those. And so that relationship took some effort and energy, but was not terribly hard to get through. Once we start expanding out and community providers who aren't employed by our health system are referring patients in, it has become harder and harder to have those conversations. To date, we've been able to, with lots of effort, overcome that. And oftentimes we show tables of our metrics of quality for adherence and benign biopsy rates and benign surgery rates compared to national averages. And we have lung nodule tumor boards. We probably minimize testing so that it's saving the money. It's those sorts of arguments that have served us well, but it's taken a lot of effort and it's not been flawless by any stretch.
Yeah.
Awesome. Thank you for those insights. So we're almost at time, but I think to get some more of these questions in, we're going to go ahead and extend just a few minutes past to about 6:05, if that's okay with you, Dr. Mazzone, just to take a question.
I spoke too long, so yeah, I can.
No worries. It's great. Okay, Anish, if you'd like to go ahead and unmute.
Yeah. Hi, Dr. Mazzone. It was great to listen to your lecture today. I learned a lot of things. So I just have a question with developments in like AI and machine learning. I know MIT has something called Sybil, which uses AI to like detect future lung cancer risk. I was wondering if you had any thoughts about the potential role of technology that in the future that could play in early detection for lung cancer screening.
Yeah. Dr. Sequist is a Sybil pioneer, so you could ask her. I think it's technology is definitely going to help lung cancer screening and other parts of medicine, of course. But for this purpose, on the very fundamental level, the ground level, not the fancy, cool stuff that we like doing the AI for, is it a cancer now? Those are going to be very helpful. But right now, it's overwhelming to our radiologists how many scans they need to read. In our health system, we have 14 or 15 chest radiologists. I mean, we're very blessed. And it's probably a third of everything they're reading right now. That's hard. When we look at quality metrics, it's clear we could probably triple or quadruple our size in the next couple of years easily. And it's going to overwhelm radiology. And that's at a big place like this. What about in community settings that don't have chest radiology and so on? So having some first read tool to highlight worrisome, the category 3, minimize the time and the effort that our radiologists are using to read these, I think is going to be critical. Helping with, automated reporting is going to be very critical to seeing these programs flourish. And beyond that, it's just all the cool stuff like the Sybil calculator tool and the other AI tools that are out there. Plus some of them like the biomarker work that's really going to hopefully help move all this to another level.
Awesome, super cool. That's super interesting stuff. I think we have time for one more question. So to turn it back to Dr. Yang here, just for the last one.
You're muted.
Thank you so much, Eli and Dr. Mazzone. That was absolutely really educational lecture. Thank you. And also, I just want to take this opportunity to thank the audience for coming. I know we have a lot of students, doctors, and lung cancer survivors here on this call, and just thank you all for joining us on this experience of learning with Dr. Mazzone. My question was just, I really appreciated how you broke down everything and then also gave the chest guidelines. And one of the chest guideline recommendations that I thought was great was the one where talking about if an individual had a high enough risk that they would be that you would still recommend lung cancer screening, and that is currently different from the USPSTF recommendations, but actually fairly similar to the USPSTF recommendations for breast cancer or colon cancer. So I was just wondering, is there any way to have a conversation between the chest team and USPSTF, or where do you see this interaction or future communication go to hopefully have the USPSTF be more like the chest guidelines?
Yeah, no, it's a great question. The chest, I've been fortunate to be involved in guidelines enough to recognize maybe what they're good for. The guidelines we produce don't make policy, so I have a little bit more latitude to say things that might push the field a little bit. Mm-hmm. So, that particular recommendation said, if your person has high net benefit but is eligible, then you should screen them. And that's complicated, right? It's their risk, it's their health. We didn't go into the details here, but we put risk thresholds and life expectancy thresholds. Ultimately, I hope that kind of thing can be built in, whether it's one of the current clinical risk predictors or an imaging or a blood biomarker. But that's not the biggest issue right now, right? Even without that, 90% of everybody who's eligible is not being screened, right? So if we can prove that we can get the people in who are eligible, screen them, do much better than we're doing now, it may open up possibilities for these other groups to be considered. USPSTF take another 5 years till they rethink this issue, I think. So it's on us to give them evidence about Sybil or about other AI or blood biomarkers or risk predictors. But in the meantime, we should focus on implementing high quality screening and getting as many people screened who are currently eligible as possible.
Great, thank you very much. And thank you again to everyone for joining us. I'll turn it back to Eli for the last word.
Awesome. Yeah, like Dr. Yang said, thank you so much. This concludes this distinguished lecture. We'd like to especially thank Dr. Mazzone for his super insightful remarks and answers to questions. So yeah, I think that's about it. Alex Potter or Dr. Yang, if you guys have any final closing remarks, you can go ahead and give those now. Otherwise, feel free to go ahead and sign off.
Great. Thank you. Thank you. I just would like to again say thank you to everybody and have a great week. Thank you.
Thank you, everybody. Appreciate it.